and welcome to the Dr. Bob Show. Doctors are doing a lot better job at taking care of cancer. We know there are certain cancers that we can prevent. For instance, if we find adenomatous polyps in the colon and we remove them, then we prevent colorectal cancer. There's also some risk factors that we have that will help us decrease the chances of getting colorectal cancer. Do you know what those risk factors are? Do you know what you can do to find an adenomatous polyp early and remove it? My guest is Dr. Raj Narayani. Dr. Narayani is a board-certified gastroenterologist, colon specialist, and he answers these questions every single day. Outstanding teacher. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about exercise, nutrition, 7.5 hours sleep. All of these are important in cutting down on the incidence of colorectal cancer. We'll be spending the entire show improving your health and my health and preventing cancers. You'll want to stay tuned. We're talking with Dr. Raj Narayani, board-certified gastroenterologist. We're talking about colon cancer. Can it be prevented? How can it be prevented? What can we do to keep the incidence down? Raj, welcome to the Dr. Bob Show. It's always great having you here.
Thank you for having me back. I appreciate it.
So tell me, what is colorectal cancer and why is it colo and rectal?
Yeah, so the colon is the large intestine or the large bowel, and the rectum is the very end of that section of your bowel. And because those two organs are contiguous, they're connected, cancers can form in either location, and they're usually just basically lumped together. More
common one than the other?
Yeah, colon's more common than rectal cancer. There's probably about 100 to 110,000 cases of colon cancer in the U.S. yearly, and there's about 50,000 rectal cancer cases yearly.
If we really were super duper good, could we prevent those cancers?
Absolutely. We've got methods by which we can screen people and remove lesions before they become cancer.
I think that's out of sight now. More common in women or more common in men?
A little bit more common in men. We like to say that if you looked across the population, your chance of getting colon cancer if you're a man is about 1 in 23, and if you're a woman, it's about 1 in 25.
So there's no free lunch for women. You can't say, well,
no.
It's more common in men. Women need to have
absolutely
the proper procedures.
Yeah.
So walk me through what happens anatomically. Where is the anatomy of colorectal cancer? You've told me where the colon and the rectum are, but tell me about those cancers and what makes them turn into cancer or stay away from cancer.
Sure. So the large intestine, the colon, and then the rectum, again, are the terminus or the end of the entire GI tract. And of course, that's the organ that processes all of the digestive material that you've consumed over the course of a day, and it produces your waste so that you can eliminate it at a time that's convenient for you. Because of the environment of the colon and all of the things that are happening there, you can sometimes see mutational changes in some of the cells that line the colon.
What's a mutational change? Now, what does that mean?
So the colon has cells that line it. Those cells function to pull water out of your digestive fluid so that you can form waste. And those cells have DNA and all the things that our cells have, and if a mutation or a change occurs in that DNA, like it might occur if you have, let's say, lung cancer from smoking or something else, then you can get a growth from that mutational change, which will allow that growth to persist so that it won't die as quickly as the remaining cells in your colon, which have a life cycle.
As a matter of fact, when you develop early cancer of the colon, it's my understanding that the body puts vessels there to nourish it and to keep that cancer growing. So we got to find it early to prevent it. So what do we do?
Yeah, so one of the ways that we identify some of these growths, these precancerous growths, which are called polyps, is that we can perform either a test to measure some sort of product of that lesion in your stool, or we can look directly at the lining of the colon doing a colonoscopy. And
so what are those different things? Let's go through those, because that's the important thing. Find it early, you don't develop colon cancer. You wait too long, you got colon cancer, and then we've got to decide how to handle that. Is that correct?
That's correct, yeah.
So walk me through what is the opportunity that the viewing audience has of examining the colon.
Yeah, so if we look at historical data, what we realize is that the incidence of colon cancer begins to rise more significantly by the time you reach age 40. And in fact, by the time you get to 50, it's significantly higher. So if you're looking at the process of trying to detect the precursors to colon cancer, the polyps for colon cancer, that's our target population. We want to begin screening people for these polyps before they have a chance of becoming cancer by doing these
tests. Age 40 or age 50?
Yeah, so actually we'll split the difference. It's 45 now. That recommendation was made as recently as just this past year. And that was based again on the observation that for many years when we were screening people starting at age 50, that we were missing a part of the population between 45 and 50 that had almost identical colon cancer incidence as the ones over 50.
So I had a patient in my office one time who self-diagnosed the fact that members in his family history got colon cancer early, and he was smart enough to say, well, then I'm going to go get checked, and lo and behold, prevented him from dying with that. So it doesn't mean everybody can wait till 45. Who needs it sooner?
Yeah, anyone with a family history needs to begin thinking about it somewhat sooner. And the age at which your family member or members developed colon cancer, or for that matter advanced colon polyps, is really what dictates when an individual should start screening themselves.
Give me an example.
So if someone has, let's say, a parent who is in their mid-50s or perhaps 60 years old, then that person should start at age 40. That's pretty much a baseline value to start. If someone had the misfortune of having a family member that was diagnosed with colon cancer at a much earlier age, let's say 42, then that person actually should start 10 years before their family member. So in their early 30s is when that person would start.
So this is an unfair question, but basically, therefore, when do you see the earliest incidence of cancer of the colon or the rectum? Is there an age that defies medicine?
Yeah, so for the most part, it's age 40, 45, 50, that range, and then certainly after 50, it begins to rise even further. Do we see colon cancer in 30-something-year-olds? We do actually, but almost always in the setting of a very strong genetic syndrome. So either an individual who has multiple family members that have had polyps or cancer, or for that matter, a known genetic syndrome that increases the risk for colon cancer and polyps in that person's entire family tree.
So in general, if I'm a person in society and I reach a certain age, 45, I need to think about early detection of colon polyps. How's that done?
So a colonoscopy is the most common way that this is done now.
What is a colonoscopy? Most people know that, but some don't.
Yeah, it's become a much more mainstream technology that people are aware of, and the process of performing a colonoscopy involves having an individual go through a laxative cleanse process to clean out their bowel so that we can see everything inside when we do the procedure, and then bringing them to usually an office facility, putting an IV in one of their veins, and then delivering.
Why would you put an IV in if you're going to look at the colon?
Yeah, well, what we want to do is be able to look at the large bowel without creating discomfort for the patient. The process of looking at that organ does involve inflating the colon with either some air or some carbon dioxide. And for people who stay awake through that procedure, it can be done. It is done often in our office. However, a lot of people might say that there might be some discomfort associated with that. So most people will select having anesthesia for the procedure, and that's delivered through the IV.
One of my good friends had a colonoscopy, and I asked him on the show, what was the colonoscopy like? He says, like a 45-minute nap. Why is that? Why was it like a nap? Because what?
Well, there's really no discomfort associated with it. When you deliver that medicine in the IV to help with the patient to sleep, the anesthetics that we use nowadays, which have come a long way, essentially put you to sleep within seconds. And then throughout the course of the procedure while you're asleep and we're doing the procedure, there's really no waking up. You're sleeping, you're breathing on your own. And then by the time we're finished, we have a way of sort of timing that anesthesia so that you begin to wake up when we're finished. And then we take you back out to recovery and you enjoy the remainder of your nap. And then we bring your family to your bedside and talk about your results. So it is really a nap for most people. Perhaps the most unpleasant process is just simply cleaning out and getting that process done so that you can get ready for the test.
So everybody that I know of has had diarrhea at some time and has had their self-cleansing of the GI tract with a GI bug that they've gotten. So it's no worse than that, is it? No
worse than that, and quite frankly, if you have a GI bug, you're going to feel terrible because you've got a fever and you've got other things going on, and that's not how you feel with this. This is just simply a matter of committing yourself to a period of time where you're drinking this laxative and you have to be near a bathroom to be able to empty all that out. You actually usually do what we call a split prep, which means that you do part of the laxative process the evening before your test is scheduled, and then you do the other part of it on the morning of. So there's actually a chance for you to get a good night's sleep, in fact, in between, if you wish, so that by the time you get up early in the morning and do the rest of it, you're ready to go.
So when the patient does wake up and you're in a room and you talk with them, what do they tell you?
They usually tell me that it was one of the best naps they've...
That's what we're going to be talking about when we come back. What's the patient say when they've gone through that? You'll be shocked at how they say, have you already done it? Or when do we start? We're talking with Dr. Raj Narayani, board-certified gastroenterologist, specialist of the GI tract, but we're concentrating on colon and rectal cancer. We've talked about colonoscopy, we talked about examination, we've talked about what it's like getting prepared for that. We talked about the patient said it's like a 45-minute nap. Is that pretty much right so far?
Almost always people are waking up and telling us it was one of the best naps they've had.
I think that is so cute. So what if you happen to say, well, I found a polyp in there. Is that bad news or good news?
It's actually good news in the sense that, you know, you're finding things in the colon at an early stage so that you can get them out during the colonoscopy rather than allowing them to grow at some point, become too big, and then have to have surgery. So,
special kind of polyp?
So some polyps are completely benign, have no chance of becoming cancer because they don't contain those mutations we were talking about earlier. Most polyps are precancerous polyps, and by precancerous, we don't mean that they're cancer, but they have enough mutations to render them at risk for cancer if they were to continue to grow and be undetected. So
what kind of polyp do you call that? You got a big long name for it.
Yeah, so they're called adenomatous polyps.
Adenomatous polyp.
Yeah.
That means that you don't have cancer of the colon, but that will take how long before it develops cancer? A couple of weeks?
Most, thankfully not that fast, but most polyps are going to take somewhere between 2 years, let's say if it's a large polyp, or maybe even as long as 10 or 12 years if it's a really small polyp.
So you've got plenty of time to begin to prepare. While you're in there and you see a large adenomatous polyp or a small one, what does the small one look like, and can you remove it?
Absolutely. Most polyps can be removed during colonoscopy, whether they're small or big. The smaller polyps are a lot easier to deal with. The larger polyps sometimes require some special techniques to remove. But polyps look like small bumps, almost like warts on the wall of the colon. And when they're very small, then practically all the tools that we use, which are basically wire loops, allow us to shave them off just in one piece, real simply, real easily.
Zip it out?
That's right. We don't have to use cautery or energy. The bigger the polyp, the more likely it is to have a very dense blood flow to it, and therefore you have to be a little bit careful, because if you try to just simply shave that polyp off or cut it off, you can cause some bleeding. So we have special techniques to help control bleeding or prevent bleeding from happening with larger polyps.
So in general, in the hands of an excellent gastroenterologist like yourself, the procedure of removing an adenomatous polyp of a normal size or small, or the small wart, is safe, or it's one that you have to be careful and call the patient the next day?
Most polyp removal is very safe, and when we can remove small polyps, let's say, without using a lot of cautery or a lot of advanced technique, then we will still call the patient typically that day or the next day to make sure we check on them and they're doing okay. They practically always are, because it's such a safe thing to do.
So when they have had an adenomatous polyp and you've removed it, what do you tell that patient? When do we have to do the next one?
Yeah, so it depends a little bit upon the number and the size of polyps that are seen, and there are guidelines that gastroenterologists will follow when they take these polyps out in order to help us to know when to bring these people back. And those guidelines are based on years of historical data that look at how polyps behave over the course of time. But I'll just tell you that the range is somewhere between 3, 5, 7, or 10 years, depending on the kinds of polyps and number of polyps that you have.
So when you remove it and you look at the adenomatous polyp, can you say, oh, that's cancer, not cancer? How do you decide if it's cancerous?
Yeah. There are features that we learn about when we train at the surface level, and our scope technology has come along a long way over the last 10 to 12 years with high-definition lenses, with features built into the endoscope technology that allow us to change the wavelength of light, that allows us to look at these polyps.
Wow.
And with all these sophisticated techniques, we can usually be pretty certain what kind of polyp it is even before we've removed it. If you have rectal or lower left colonic sigmoid polyps, we call them, they're much more likely to actually be benign compared to, let's say, polyps on the right side of the colon, the ascending colon, where they're almost always precancerous.
So on the left side, when you're going down to the sigmoid and the colorectal area, the end of the pathway for stool, that's an area where you see more of, or you have to be more careful with that. You got to refresh when you were saying the terminology, refresh what that makes you feel. Safer or less safe?
Yeah, if they're small, pale colored polyps, usually we feel pretty safe about those. In fact, sometimes we don't always even remove every single one of them, because you can sometimes see numerous of those because they're usually benign. When they're larger on the left side, or even if they're small on the right side, they're almost always precancerous, and we will always take those out.
Okay. Do you have to send them to the pathologist to look under the microscope to give you the final diagnosis there?
Tissue that's removed from the colon is always sent for analysis, because even though the odds of having, let's say, a small focus of cancer and a small polyp is exceedingly low, we like that reassurance, we want that, and so we have the pathologist look at the tissue for all polyp specimens that are removed, and typically within about 3 to 5 days they'll send us back a report that tells us whether the polyps were adenomatous, were they benign, were there any high-grade features, and then we will then act on that information when we're talking about using guidelines to tell patients when to come back next.
So when I'm looking at television, I see advertisements, and I see advertisements that say, all you have to do is take a little smear from your own stool, send it off to the company, and they'll tell you if the chances that you've got colon cancer or not. What's going on with that? Is that acceptable? Or are they going to miss some? Are they going to pick things up early? Look at the DNA? I think it's a very important part of medicine.
Yeah, we know that there's more than one way to skin a cat, as you'd say, right? You can screen for colon cancer and colon polyps using other techniques, some of which have been around a long time. The FIT test, the fecal immunochemical test, which is the traditional card kit that you take home with you, and you wipe a little bit of your stool sample on the card and then mail that back in. That's been around for decades. It's a technology that has evolved a little bit to become more and more accurate, but even at its best, it's still not terribly accurate, and certainly not as accurate as a colonoscopy for finding polyps and for finding colon cancer. But for the individual who may be a little apprehensive about having a colonoscopy, or perhaps is in a situation where their health would make it very difficult to put them to sleep for a colonoscopy, it's a reasonable alternative. The fecal DNA test that has been developed within the last few years
What's it called?
It's called the Cologuard test, and it's technically speaking a multi-target stool DNA test. So, as you were saying a little bit earlier, instead of just looking for blood like the FIT test does, it looks for a combination of both blood and abnormal DNA that might be shed or released from polyps or cancer growing inside the colon.
So it's getting more sophisticated evaluation of that person's stool. Still, there's nothing like looking and seeing and knowing what you're really doing from that standpoint. What's the effectiveness of somebody doing a Cologuard? Are there statistics on that?
Absolutely, yes. So Cologuard testing will usually find colon cancer if it's positive about 2.5% of the time. And it'll find polyps in 50 to 60% of cases when that test is positive. But that means that certainly there are going to be positive tests that are false positive, because you'll do the colonoscopy and you won't find anything. And unfortunately, there are also false negatives, which are kind of scary, because if you have a Cologuard test and you decide to do that in place of a colonoscopy and then you have a negative result, you're led to believe you're okay, but in reality, you actually still have a small chance of having a colon cancer or an advanced polyp
And that would be false negative.
Correct.
That's there. So it's important that you know what's going on, so you'll have the evaluation. We start at age 45 now, in general. That's the safe age to say. How often do you repeat colonoscopy?
If you have polyps, it may be, again, between 3, 5, or 7 years. If you don't have any polyps and you don't have any family history, so you're not at high risk otherwise, it's every 10 years. That's pretty nice, actually, because a lot of the other cancer screening tests that we do, as you know, for prostate cancer and breast cancer, have to be done a lot more frequently than that. So people find that appealing if they don't have any business inside that requires them to be a little bit more vigilant. And we typically continue colon cancer screening, or the recommendation for colon cancer screening, until around age 75 to 80. It depends a little bit upon the individual's health. If they're very healthy, we might do it even into their 80s. If they're in not so great health, we might stop in their early 70s.
Warning signs would be bleeding, the size of the stool. What is the size of the stool? What's that got to do with a warning sign?
Yes, so these are symptoms that we might be looking for that would be outside the bounds of routine screening, right? Screening applies to people who say, I feel well, I don't have any symptoms, but I just want to get checked and make sure I'm okay. But symptomatic complaints that raise concern would be bleeding, a change in the shape of the stool. If you imagine that if you have, let's say, a rectal cancer, which sometimes will grow around the wall of the colon and basically narrow it down, then solid stool that's coming through is going to get shaped in a certain way to become thinner, and we call it pencil-like stools. And if that happens, then that's a reason to be concerned and potentially to come in sooner for a colonoscopy.
So if I'm 25 years of age, which I'm not, but if I were 25 years of age, are there some things that I can do to make me stronger and healthier where I have less chance of getting colon cancer?
Yeah, I like to tell people...
And that's what we'll be talking about when we come back. A lot of information. There's some things we can do at an early age that will prevent us or decrease the chances of getting lots of different kinds of cancers, including colon cancers. You want to stay tuned and know what that is. We're talking with Dr. Raj Narayani, board-certified gastroenterologist, and we've been talking about what we can do to prevent getting colon cancer. Now, there are some lifestyle changes. That means what you and I can do. What are some lifestyle changes that people need to do to stay healthy and stay away from colon cancer?
Yeah, you know, there's information to support the fact that if you're smoking or if you're drinking or if you're overweight, that you potentially are at increased risk for colon cancer during your lifetime. It may be about a 10 to 20% chance higher than the average risk population. So we try to tell people to live well, you know, exercise, eat right, try to limit your red meat consumption, try to increase your fiber consumption.
Fiber consumption, now, what's fiber? Because I think that's an important thing that people have to read, look at, and know what they're getting.
Yeah, I think if you want to know a good way to get fiber in your diet, let's say, then plant-based items, basically fruits and vegetables, foods like beans and legumes, berries in the fruit category are great.
So what do they do in the GI tract that makes them good, makes them fibrous? Why are they fiber?
Fiber promotes basically motility. There are breakdown products from foods that stay in the space of your gut rather than get absorbed, and they help participate in the process of pulling water into the stool so that you can have bowel movements on a regular basis. And if you do that and you lessen the chance that there's stasis in your gut, and then you do it in the form of, let's say, things like berries where they have some antioxidant properties as well, you're probably lessening the chance that you get those mutations we were talking about in the DNA of your cells.
Regular evaluation from your doctor?
Absolutely.
I think that's a key issue all the time. Raj Narayani, you're a fabulous teacher. I mean, I just love having you on the Dr. Bob Show because you're full of information that's very important to me and to the viewers. Thank you for coming to the Dr. Bob Show.
Thank you for having me again.
A lot of information. Remember those 4 things that we like. Number 1, it's exercise. What does exercise do? Helps you lose weight. It helps you decrease the incidence of having problems in the GI tract. It makes your GI tract healthier, and when it's healthier, you're happy and less chances of getting colon cancer. Eating the proper nutrition. So be sure that you know you're eating fruits and fibers. Look at the box of the food that you're eating. Talk to your grocery store. Find out which foods have a lot of fiber. There are some foods that are really fiber-oriented, plant-based foods. So be sure you get that. Be sure that you're getting your 7.5 hours sleep. The body performs well if you give it rest. And the same thing goes on for your colon. If you're running around too fast lifestyle, drinking a lot of coffee, smoking a cigarette, all that's bad for your GI health. So be sure that you're getting your 7.5 hours sleep. And most of all, what is it we like in the Dr. Bob Show? Is that laughter in your life. Does laughter involve health with the colon? You better betcha it does. If you're happy, the body's happy, and the body will do better. So remember, eat properly, sleep properly, eat properly, and most of all, it's that laughter in your life. You stay happy and you'll stay healthy.